everybody. Welcome to Congenital Heart Academy in our first activity of 2022. I wish you all a blessed and healthy new year, and I hope you can join us for a lot of activities during this year. I have something to share with you guys real quick. So please ask you to, first of all, type all of your questions during the session on the Q&A chat box. We are going to have a nice panel of specialists together with Dr. Anderson to discuss things after the lecture. So please, your participation is what makes this very interesting. And so please type your questions on the Q&A chat box. Follow us on social media. We are going to announce there everything that we are planning for this new year, and is a lot of nice stuff. And we are happy to tell you, we told you guys this already, but just to remind you that we are one of the scientific partners of the World Congress of Pediatric Cardiology and Cardiac Surgery. Is going to be in 2023. August 27 to November the 1st. The program is being made with a lot of care. It's going to be amazing. Dr. Gil Vernovsky is the co-chair. So he's planning a lot of nice things together with the scientific committee. So please, all of us, save the date and think about join us on 2023. I'm very, very humbled and very honored to be the co-chair of marketing and social media for this conference. So we are preparing a lot of things for you guys during the conference and this next 1 year, this 1 year and a half that we have ahead before the Congress. We are planning to do a lot of nice stuff. So please be aware that we are going to start to have a lot of nice things. We are planning great things for you guys. And we have Dr. June with us today. He is one of the heads of this amazing event that is the host training. So this is the hands-on surgical training. Now in 2022, they're starting with the TGA. If you're a surgeon and you want to improve your skills on congenital heart surgery, please join this very nice training with our colleagues from Toronto. And on the January the 25th, we are going to have our second journal club in the memory of Dr. Gary Webb. We are going to discuss a surgical paper this time. It's going to be very nice. We are going to have amazing surgeons as panelists to debate. It's a very good opportunity to improve our knowledge, know how to analyze better scientific paper, and learn more about this, some surgical techniques as well. On the 27th of January, we are going to have our fetal series. I'm so sorry I don't have the flyer yet, but as usual, Dr. Rima is preparing very nice lectures for us on the fetal series. She always makes things in a way that we have first a basic talk for people like me that knows nothing about fetal cardiology, and then she has the second lecture more in intermediate knowledge, and then she has something that is more advanced for people who are really into the field, so we all can learn on this fetal series. Please join us on the 27th. Now Dr. Anderson is going to talk to us a little bit about what he's planning on his series for this year. Today we're going to talk about the valves of the heart, and then on January we are going to have still the ventricular outlets. Then we are going to start the sequential segmental analysis of the heart. He's going to divide this in two parts, and then he's going to tell us what else he's planning for this year and the way this is going to work. We have amazing people helping him, Dr. Diane, Adrian, and Justin. So in my opinion, this approach is making things even more interesting and easier to understand. So now with you, Dr. Anderson. Thank you guys for joining us today.
Well, thank you very much, Grace, for giving me the opportunity to speak to all our attendees as we start this new session, which now for 2022. So those of you who were here with us for the latter part of the sessions that we put on for 2021 will know that we're extending these sessions now so that I give you the introduction as to what we're going to do, and then Diane Spicer shows you the gross autopsy, and then the real innovation has been the contributions that have been made by Justin Tretter using virtual dissections. And this is what we are continuing as we move into 2022. So as Grace has just shown you our first two sessions, today and in 2 weeks' time, we are catching up with what we were unable to complete in 2021 on normal anatomy. So today you're going to see the atrioventricular valves. And of course, the atrioventricular valves occupy the ventricular inlets. In 2 weeks' time, we'll talk about the arterial valves, and they occupy the ventricular outlets. And that will complete our assessment of normal anatomy. So, of course, the basis now for diagnosing the congenitally malformed heart is sequential segmental analysis. So in February, as Grace has told you, our sessions are going to be devoted to sequential segmental analysis. And what I'd like to discuss with you is the seeming schism between our approach and that put forward by my very good friend Richard van Praag. But what I'd like to show you is that in reality, there is very little difference between the two systems, and hopefully we can bridge the gap in those two sessions that will take place in February. And then we're going to start our analysis of the congenitally malformed heart. I'm not entirely sure how we're going to do that. I'm going to discuss that with Diane, with Justin, with Norman, and with Adrian, but we will work out a program and Grace will share that with you. And hopefully that will continue from March through the rest of the year. And over the year, we will be discussing the approach that seems to be becoming popular. Me as the chair, as it were, Diane showing you gross anatomy with video clips. And I hope Adrian is also going to be able to join us to do this. And then Justin emphasizing everything with virtual dissections of living data sets. And that will be our approach to look at the overall congenital cardiac anatomy. So Grace, now back to you, and let's start today's session. What we are looking at today is the atrioventricular valves.
Perfect. Thank you, Dr. Anderson. Let me share the video now.
Well, good afternoon again to you all, ladies and gentlemen, and welcome to the 2022 session of Congenital Heart Academy devoted to the anatomy of the congenitally malformed heart. So to remind you, to begin our sessions for 2022, we are completing our discussion of normal cardiac anatomy. And we're going to have two sessions during January. First of these today, when we're going to discuss the atrioventricular valves. And as you know, the atrioventricular valves occupy the ventricular inlets. And the key point about the atrioventricular valves is that they are closed during ventricular systole. In our second session, which will complete our analysis of normal cardiac anatomy, we will discuss the arterial valves. And as you know, the arterial valves close during ventricular diastole, and they are part of the ventricular outflow tracts. And we can understand the anatomy of the valves when we look at the difference between systole and diastole. So here I'm showing you a picture during systole. The atrioventricular valves are closed. The arterial valves, of course, are open because the ventricle is contracting to force the blood out. Now, during ventricular diastole, of course, the atrioventricular valve is now open, whereas the arterial valve is closed. And it is this difference between opening and closing of the valves that determines the differences in their anatomy. And that is what we are going to discuss during our first session, because the anatomy of the atrioventricular valves is dominated by the fact that they are a valvar complex. They have an annulus, although that, as I'm going to show you, is not a very good term. But the key to the understanding of the atrioventricular valves is that to withstand the full force of ventricular contraction, not only do they have leaflets, but they have tension apparatus. And the tension apparatus is supported by the papillary muscles. And when we consider the anatomy of the atrioventricular valves, we have to consider all of these parts working in harmony, because it is only if they work in harmony that the valve functions properly. And this functional anatomy of the valve was emphasized a very long time ago now by Perloff and Roberts in this seminal article, which, as you see, was published in 1972. So this is how we need to approach the valvar complex. I'm showing you here the parietal part of the morphologically left ventricle. We're looking at it from the septal aspect. So we're looking from the front towards the back. And there you see how the leaflets of the valve are attached within the atrioventricular junction. And as I'm going to explain, I'd much rather consider this as the atrioventricular junction, because I'm going to show you it's difficult to define a specific annulus. So the leaflets are supported by the atrioventric junction. Discuss this in some detail very shortly. And you're seeing them here in their closed position. And then you see how it is the tension apparatus, the tendonous cords that link together the leaflets with their supporting papillary muscles. And then the papillary muscles themselves are supported by the ventricular walls. So we're going to look at these components of the valvar complex one by one. Now the complex is the same in the mitral valve, tricuspid valve, but what we are going to emphasize is that there are fundamental morphologic differences between the two. And for a large part, those differences relate to the leaflets. But if we are to understand those components now in the setting of clinical anatomy, where you see the heart as it lies within the chest, it is important that we as morphologists also describe the heart as it lies within the chest. And this is something we failed to do for a very long time. I still don't understand why it was that anatomists such as myself, pathologists, when we were looking at the isolated heart, we took it out of the body and we positioned it on its apex in what we call the Valentine position. We've discussed this before, and we've emphasized the importance of attitudinally appropriate nomenclature. And I make no excuses for saying that we must repeat all of this information today. Because nowadays, this is how you are able to see the atrioventricular valves. This is an exquisite virtual dissection that has been made by my good friend and colleague, Shumpei Mori. Now, Shumpei initially was working in Japan, in Kobe. Now he works in the arrhythmia section at the University of California in Los Angeles. This is one of the exquisite virtual dissections he made quite some time ago. And as you see, he has put the heart back into the body so that we see it as you see it during life. And so when we describe the components of the valve, we should take note of the components of the body. So the top of the image, as we see now, is towards the head. And the head, of course, is superiorly located. The bottom is towards the feet, and that is inferiorly located. And what you see at the bottom of the screen is the diaphragmatic surface of the heart. Now it's an oblique cut so that you can look down the barrels of the ventricles, but to all intents and purposes, what you see to your left hand is the right side of the heart which is also anterior. And what you see, right hand, is the left side of the heart, which essentially is posterior. And this is how we should be describing the leaflets of the atrioventricular valves. So if we start by looking at the tricuspid valve, you see that one of those leaflets is adjacent to the septum. And when we see the heart in attitudinally appropriate position, the septum is posteriorly located. The largest leaflet of the tricuspid valve is positioned antero-superiorly. But currently, we have problems when we come to describe the third leaflet of the tricuspid valve. When I show it to you in attitudinally appropriate fashion, as demonstrated by Shumpei, then you can see that there is no doubt but that the leaflet is inferiorly positioned. It's lying along the diaphragmatic surface of the right ventricle, and the diaphragm is inferiorly located. So we should now be calling this the inferior leaflet. It is a mistake to call it the posterior leaflet. As you can clearly see, it is the septal leaflet that is posterior. So let's look at the mitral valve. And the mitral valve has two leaflets. As I'm going to emphasize, those leaflets wrap themselves round one another. It's more or less correct to describe these leaflets as being anterior, posterior, but it's much more accurate to describe them as being aortic and mural. And we're going to emphasize why it is appropriate to consider them as being aortic and mural. But perhaps the most important feature of the attitudinal approach is to describe the positions of the papillary muscles. So this is what we're going to concentrate on initially to show you why we need to take an attitudinally appropriate approach when we are describing the components of the atrioventricular valves. Because if you look at most of the textbooks these days, you see that papillary muscle that I've emphasized with the star described as being posteromedial. But as you are going to see very shortly, when we look at the heart, attitudinal fashion, it is anterior to its counterpart. And indeed, the appropriate name for this papillary muscle, as we will emphasize, is inferoseptal, with the other papillary muscle that you can't see in Shumpei's cut being superolateral. So now I am joined, as I have been in the final sessions of last year, to demonstrate these features to you by video demonstration. So first of all, Diane Spicer is going to join us again. I will remind you, Diane now is working at All Children's Hospital in St. Petersburg in Florida. So Diane is first going to illustrate to you the importance of the attitudinal approach, and then that is going to be reinforced by virtual dissections made by Justin Tretter, and Justin is still working at Cincinnati Children's Hospital, although very shortly he's going to leave Cincinnati Children's Hospital and he's going to transfer to the Cleveland Clinic. But he is going to continue to share with us his experience using virtual dissection. So now let's see, first of all, Diane's videos, and then Justin's reinforcement of that with virtual dissections, showing us the significance of the attitudinal approach.
When we look at the heart in Valentine position, the long axis of the heart actually lies parallel with the long axis of the body or the spine. When we place the heart back into its attitudinally appropriate position, the long axis of the heart is roughly at a 45-degree angle to the long axis of the body or the spine, so that this surface here lies against the diaphragm. When we cut the heart in short axis and look at it from apex to base, we're actually looking at it in the left anterior oblique orientation, and actually from anterior left towards posterior right. if we look at a short axis view of a normal heart, we can compare the Valentine position nomenclature with that of the attitudinally appropriate nomenclature. So in the Valentine position, this is anterior and this is posterior. This is right and this is left. In attitudinally appropriate nomenclature, this is superior and this is inferior. Here we have the anterior surface of the heart and the posterior surface of the heart. So with the attitudinally appropriate nomenclature, this is the diaphragmatic surface. When in the Valentine position, this surface would be against or towards the spine or the posterior aspect. And that is incorrect as far as nomenclature goes. This is the tricuspid valve. So it has the three leaflets, the septal, the anterior superior, and the inferior leaflet. You'll note that this leaflet is towards the diaphragmatic surface and not towards the spine in attitudinally appropriate position. As well, there are two papillary muscle groups within the left ventricle and supporting the mitral valve. In attitudinally appropriate nomenclature, this papillary muscle is actually superior and lateral, rather than the old term when looking at the heart in Valentine position, anterior and lateral. The papillary muscle that lies against the inferior surface is actually more medial or inferior and septal, and not in a posterior and septal position, because this papillary muscle group is closest to the diaphragmatic surface.
So in this CT data set, we're looking directly from the anterior perspective of the chest wall with the chest wall translucent, looking at the cardiac mass. We'll then remove the heart from the chest. We'll stand it up on its apex in the Valentine orientation. And as we zoom up, we'll go inside the cardiac chambers. So this is a 4-chamber-like view, standing the heart up on its apex. And if we ignore the orientation of the heart to the body, then you can appreciate how in this Valentine orientation, if we look at the tricuspid and mitral valve, that one would call this leaflet wrapping around anteriorly as the anterior leaflet. This leaflet, which is directly posterior from us, is the posterior leaflet, and then the septal leaflet of the tricuspid valve. Likewise, one would call this leaflet wrapping around anteriorly as the anterior leaflet of the mitral valve, and this leaflet directly posterior as the posterior leaflet. However, if we go into a short axis view and we try to orient ourselves of how the heart orients to the body, and we'll put this orientation cube for reference. So now we're looking up from the apices of the ventricles at the tricuspid and mitral valve. Here's the diaphragmatic surface, which is inferior. Here's the F for foot, which is in the inferior direction. And so that leaflet that we called posterior in the Valentine orientation is actually inferior. It's inferiorly resting along the diaphragmatic surface of the right ventricle. The leaflet we called anterior not only wraps from being anterior in the direction of this A face of the cube, but then goes up towards the head of the body, so superior. So the anterosuperior leaflet of the tricuspid valve, and then we retain the name the septal leaflet of the tricuspid valve. If we look at the mitral valve, then we can appreciate how the leaflet in the Valentine orientation we called anterior is in fact more superior, heading up towards the aortic valve. So we refer to this as the aortic leaflet of the mitral valve, and then the leaflet along the free wall of the left ventricle goes from being in a more inferior position towards a more posterior and leftward position. So we call this the mural leaflet of the mitral valve.
So now you've seen how important it is to describe the components of the valvar complex in attitudinally appropriate fashion. We can now hone down and we can look at the different parts of the complex itself. So let's start with a discussion of the so-called annulus. And I say so-called because you see in the image you're looking at the moment, I put annulus in inverted commas. And that is because the so-called annuluses of both mitral valve and the tricuspid valve are integral parts of the atrioventricular junctions. The valvular leaflets are tethered and supported within the atrioventricular junctions, but it is a mistake to think of the annuluses as being part of a well-formed fibrous skeleton. In fact, in reality, there is very little skeleton supporting the components of the heart, and that is one of the myths of cardiac anatomy. And we're going to discuss that very shortly when we look at the components of these fibrous entities. So let me take you back for a moment to share with you the developmental considerations we looked at the end of last year. Now here I'm looking down on the atrioventricular canal of the developing human heart at the conclusion of the embryonic period of development. This is what we call Carnegie stage. You'll remember CS stands for Carnegie stage. This is Carnegie stage 23. The embryo at this stage is 8 weeks old. And these are the reconstructions that we looked at all last year, made by Professor Wout Blumers, Dr. Jill Hickspoors from the University of Maastricht in Netherlands. I emphasized to you when I last showed you this reconstruction how, at the end of the embryonic period, the normal heart is still remarkably like atrioventricular septal defect with common atrioventricular junction. Because what you see there in the sort of orange, in the purpley brown color is the conduction system, which is emerging beneath the atrioventricular cushions at the crux of the heart. And what you see in yellow is the atrioventricular canal myocardium, and it is still remarkably like a common atrioventricular junction at this stage, where we have had completion of cardiac septation. And I also emphasize to you that despite the fact cardiac septation has been completed, as yet the aortic root has not been wedged between the developing mitral valve and the developing tricuspid valve. And so you can see that what will become the mural leaflets of these valves are still relatively hypoplastic. We can also look at that by turning the reconstruction round and looking at it from the aspect of the apex of the ventricular mass towards the atrioventricular junction. Remember again, you are seeing the atrioventricular canal myocardium in yellow. And I hope you note how it is still essentially a common structure. And you can see the developing conduction system carried on the crest of the muscular ventricular septum, and it is penetrated into the atrial mass at the crux of the heart. And this is because, as yet, we have not had the inferior expansion of the right and left atrioventricular junctions. And as yet, the aortic root has not been incorporated into the left ventricle so that it wedges itself between the developing aortic leaflet of the mitral valve and the septum. So there you see what will become the aortic leaflet of the mitral valve. And at this stage, it is draped across the crest of the muscular ventricular septum, and it is continuous with what will become the septal leaflet of the tricuspid valve. And I'd like you to remember that area shown by the star, which is an area of fibrous continuity between what will become the leaflets of the mitral and the tricuspid valves. So at the end of the embryonic period of development, there is still a lot that has still to happen before we get the definitive ventricular inlets. And we're now going to emphasize the 2 steps of normal cardiac anatomy that reflect the changes that have still to take place, the inferior extension of the atrioventricular junctions and the wedging of the subaortic outflow tract. Because it is that inferior expansion of the atrioventricular junctions that produces the important area that we call the inferior pyramidal space. It is the incorporation of the subaortic outflow tract between the aortic leaflet of the mitral valve and septum that produces an area with which many of you will be unfamiliar. And that is what we call the inferoseptal recess. So now we're going to take these two processes and we are going to look at what happens after they have taken place. So we're going to look at the development of the inferior pyramidal space and the inferior.
This is an opened right atrioventricular junction. You can see the oval fossa, the coronary sinus, and the hinge point of the tricuspid valve. During development, the atrioventricular canal myocardium becomes part of the atrial segment or the vestibule. And this produces separation between the vestibular myocardium and the ventricular mass. So I can dissect away the vestibular myocardium and expose the inferior pyramidal space, or that fibrofatty plane that separates the vestibular myocardium from the ventricular mass. If we look at the heart on short axis, the expansion of the atrioventricular canals during development allows for the aorta to become deeply wedged between the tricuspid and mitral valves. Here I've removed the non-coronary leaflet, and this shows how deeply wedged the aorta is between the atrioventricular valves. That expansion inferiorly of the atrioventricular junctions allows the floor of the inferior pyramidal space to form and also allows for the fat at the atrioventricular grooves to become continuous with that fibrofatty plane at the floor of the inferior pyramidal space. Here you can see the artery to the atrioventricular node extending from the distal right coronary artery at the floor of the inferior pyramidal space. This is the left ventricular outflow tract of a normal heart. And here is the mitral to aortic valve fibrous continuity. This is the non-coronary aortic valvular sinus, and there's the right coronary orifice. When the aortic valve is normally wedged between the atrioventricular valves during development, it lifts the mitral valve away from the interventricular septum, and we have formation of the inferoseptal recess. Looking at the short axis cut that we saw earlier with reference to the inferior pyramidal space, which is here, I've removed the aorta to mitral valve fibrous continuity, and you can see how the aortic valve, being deeply wedged between the tricuspid and mitral valves, lifts the mitral valve away from the interventricular septum, so that the inferoseptal recess is here and just at the apex of the inferopyramidal space.
We'll continue with the same CT data set and the same orientation, looking in short axis up from the apices of the ventricles at the mitral and the tricuspid valve. We'll make the myocardium translucent and pay attention to the epicardial fat, looking at the right inferior and left inferior AV grooves, where this epicardial fat will heap up in between with the superiorly directed apex of the inferior pyramidal space. We'll rotate leftward to look at the left ventricular outflow tract, looking at the aortic leaflet of the mitral valve, its right fibrous trigune, this fibrous tissue intervening between the right fibrous trigune and the location of the membranous septum, which is the roof of the infraseptal recess. We'll mark these with infraseptal recess in orange, the membranous septum in blue, the virtual basal ring of the aortic root in green. And then we'll again make the myocardium translucent to look at the relationship to the inferior pyramidal space. And you can appreciate that the superiorly directed apex of the inferior pyramidal space overlaps on the rightward aspect of the roof of the infraseptal recess, with the apex of the infraseptal recess being inferiorly directed.
So it is only after we have had formation of the inferior pyramidal space by expansion of the atrioventricular junctions, wedging the aortic root to give us that inferoseptal recess that Diane and Justin have just shown you. Only after those steps have taken place do we get formation of the so-called annuluses. And in a consequence of that step, the separation between the atrial and the ventricular muscle masses sequestrates the atrioventricular canal myocardium to become vestibules. And having been separated from the ventricular myocardium, we do not, in most instances, get formation of so-called fibrous annuluses. We can see them. So this is how people imagine a fibrous annulus. This is a cross-section across the left atrioventricular junction. You're looking at the hinge of the mitral valve, and they're supporting the hinge of the mitral valve. We have a well-formed fibrous cord. Not only does it support the hinge of the valve, it separates the atrial myocardium that you see to your right hand from the ventricular myocardium to your left hand. But this is very much the exception. And hardly ever do we get such a well-formed fibrous ring extending throughout the mural atrioventricular junction. In fact, in the majority of normal cases, we get a situation like this, when rather than a cord-like structure supporting the leaflet, we have a curtain-like structure supporting the leaflet. This is now coming to prominence as so-called disjunction. But this, in fact, is a normal feature of support of the leaflets of the mitral valve, and it is found in 95% of all normal atrioventricular junctions. This is a cut from the same heart, and this time there is nothing separating the atrial myocardium from the ventricular myocardium other than the fibroadipose tissue of the atrioventricular junction. And this is why I prefer to consider the tethering of the leaflets within the atrioventricular junction rather than describing an annulus. And that is more so the case when we look at the tricuspid valve. So here is a cross-section of the tricuspid valve. There in brown, you see the atrial myocardium. Also in brown, you see the ventricular myocardium. There is the tethering of the leaflet, but there is no fibrous cord supporting the leaflet. Instead, the atrial myocardium, which overlaps the crest of the ventricular myocardium, is separated from the ventricular myocardium by the fibroadipose tissue of the right atrioventricular junction. And it is much better, I believe, to think of it in terms of a junction than it is in terms of an annulus. Now, if we turn our attention back to the left atrioventricular junction, we have a further problem in describing the annulus, because in the mitral valve, as we're going to see very shortly, one of the leaflets is in fibrous continuity with the aortic valve. So that is not supported by the atrioventricular junction at all. So in the left atrioventricular junction, we need to distinguish between the mural part and the aortic part, because it is only in the mural part that there is potential continuity between the atrial and the ventricular myocardial masses. You see that all the time when you do a parasternal long axis echocardiographic section, and I'm showing you the equivalent of that. In fact, it's a little exaggerated here. This is one of Diane's beautiful pictures because she's opened a little more the left atrioventricular junction. But there, superiorly, you see the fibrous continuity between the leaflets of the aortic and mitral valve, and this is much better described as a curtain rather than an annulus. And then within the mural junction, as you have seen, it is exceedingly rare to find fibrous cords. More often they are shelves, but I believe it is better to consider this as the mural atrioventricular junction. And then if we look at another of Schumpeter's beautiful virtual data sets where he has stripped away the atrial myocardium, he has shown you in the red semilunar arrangements, the hinges, the leaflets of the aortic valve, we can now see that area where at supporting the aortic leaflet of the mitral valve, we have an area in fibrous continuity with the leaflets of the aortic valve. And this is the aortic mitral curtain. You see it occupies a short, small part of the overall circumference of the left atrioventricular junction, with the much larger part being the mural atrioventricular junction. Now, if we open out the heart, we can then see that area which has been considered to represent the central fibrous body. Now, Diane and Justin have already shown you the consequence of wedging of the aortic root, how that produces the infraroseptal recess. And I'd like to emphasize that again now relative to the aortic mitral curtain. Because there you see the leaflet of mitral valve. As I say, we like to call this the aortic leaflet of the mitral valve because you see it's in fibrous continuity with the non-coronary leaflet of the aortic valve and the left coronary leaflet of the aortic valve. And it is the area between the two that is the aortic mitral curtain. And this certainly is not an annulus. It is part of the left atrioventricular junction. But previously, we've considered the end of this area of fibrous continuity as the right fibrous trigone, and we've considered the right fibrous trigone to be continuous with the membranous septum to form the central fibrous body. We are now aware that there is another key element forming that central fibrous body, and this is what you have already seen. It is the roof of the infraroseptal recess. And in this picture, again taken by Diane, we see beautifully the extent of that infraroseptal recess. So now we know that the overall components of central fibrous body are not two, but are three. Right fibrous trigone, the infraroseptal recess, and the membranous part of the ventricular septum.
This is a long axis view of the left atrioventricular junction. Here you can see the coronary sinus within the fibrofatty tissue at the left atrioventricular groove. This is the anterior leaflet of the mitral valve, which has been bisected in this dissection. And here is the hinge point or the annulus of a portion of the mural leaflet of the mitral valve. This is the only area where there is potential continuity between the atrial and ventricular myocardium. The anterior leaflet of the mitral valve is all that separates the inlet from the outlet within the normal left ventricle, and it is sometimes referred to as the aortic leaflet, secondary to its fibrous continuity with the aortic valve. The aortic valvular leaflet that has the most fibrous continuity with the mitral valve is the non-coronary leaflet, typically with a portion of the left coronary leaflet also in fibrous continuity. Where the mitral valve is attached to the aortic valve, there are dense fibrous tissues, and these areas are typically referred to as the left and right fibrous trigones. The membranous septum lies adjacent to the interleaflet triangle between the right and non-coronary leaflets, and the roof of the infraroseptal recess is here. The central fibrous body is the area that is formed by the right fibrous trigone, the roof of the infraroseptal recess, and the membranous septum.
Professor Anderson will often refer to the phrase, the proof is in the pudding. And while the anatomical evidence is pretty clear, what really hit it for me is the developmental evidence and the temporal sequence of development of the AV valves and formed by the endocardial cushions including this area of fibrous continuity between the tricuspid and mitral valve that forms the roof of the imperceptible recess, which happens before transfer of the aortic root over to the left ventricle with resorption of the subaortic infundibulum, which subsequently creates the area of fibrous continuity between the aortic and mitral valve and the right fibrous trigoon. So those two components that form two of the three components of the central fibrous body develop in different time points in cardiac development. So here we're using multiplanar formatting. I'm just showing one of the 2D images. I've gotten into the short axis of the virtual basal ring plane of the aortic valve, and then I'm cutting down in a long axis of the mitral valve leaflet. And we'll go immediately towards the right fibrous trigoon. So here we're starting to see that rightward lateral thickening. And so we're going to mark this here. It's white on our 3D image. It'll be an orange arrow. And we'll go over to our 3D virtual dissection in a 3-chamber cut. And you can see that orange arrow marking the right fibrous trigoon. I've colored again the imperceptible recess, its roof in orange, the membranous septum in blue, the virtual basal ring plane of the aortic root in green. Then we'll rotate so we can better appreciate the roof of the imperceptible recess. And now we'll go back into our multiplanar formatting. Now I'm showing an image that looks more like a 4-chamber cut. And so we start to see the atrial buttress. And so there is our mark of the most rightward aspect of the right fibrous trigoon. And then we'll start to dissect further rightward. And so here I'm going to mark, this is the imperceptible recess, which is the fibrous continuity between the tricuspid to mitral valve, again undermined by the atrial buttress. And this is going to be colored red. We'll go back to our 3D reconstruction. You can see the red arrow is right in the middle of the roof of the imperceptible recess. So the orange marking the right fibrous trigoon and the red arrow marking that area we marked in the middle of the imperceptible recess. So those are two of the three components of the central fibrous body, the third component being the membranous septum. And then we'll tilt back so we're looking straight in this 3-chamber cut, and we'll make the myocardium translucent to look at the inferior pyramidal space with its superiorly directed apex, which overlaps on the rightward aspect the imperceptible recess, with the apex of the imperceptible recess being inferiorly directed.
So now you've seen the components of the annulus, and we've emphasized again the importance of the inferoceptal recess contributing to the central fibrous body. So let's now turn our attention to the moving components of the atrioventricular valves. And these, of course, are the leaflets. And I'm going to describe the moving components as the leaflets, both in the atrioventricular valves, which we're looking at this week, and also in the arterial valves, which we will be looking at in our next session. Now, it remains controversial as to how many leaflets there are in both of the atrioventricular valves. To determine the leaflets, I believe we need to look at them when they are in their closed positions. Now, I was sent this beautiful picture of the mitral valve a very long time ago. Sent to me while I was still working at Brompton Hospital. It was sent by this man, Dr. Galistan from Armenia. I've never met Dr. Galistan, but I am indebted to him for sending me this beautiful picture. It's showing the surgeon's view of mitral valve, normal mitral valve, and it's showing it in its closed position. And again, I emphasize we should be describing the supporting components of the valve as the junction, and the vestibules of the atrial myocardium are inserted into the junction. Now, the key to understanding the mitral valve is that its two leaflets close along a primary zone of apposition. And then to let the leaflets close snugly, there are slits along the more extensive leaflet, which is the mural leaflet. And typically we describe 3 scallops in the mural leaflet, and they are opposed to the opposite areas of the aortic leaflet. But then there are further components of the skirt of leaflet tissue at the margins of the zone of apposition between the leaflets. And the key here is that the zone of apposition, the opening within the zone of apposition on either side, does not reach to the junction. So overall, we have a skirt of leaflet tissue that is guarding the atrioventricular junction for both the mitral valve and tricuspid valve. Now, how many leaflets are there? If there is but a solitary zone of apposition, then to me, that indicates that in the mitral valve, we have 2 leaflets. And it is the end of those zones of apposition that traditionally are described as being the commissures. Why do we describe the ends of the zone of apposition as the commissures? Because typically we as morphologists look at the valve like this when it is open rather than when it is closed. And then we can see very nicely the aortic leaflet, and it guards less than 1/3 of the overall circumference of the left atrioventricular junction, but it is much deeper than its component part, the mural leaflet, that guards 2/3 of the overall circumference. And then, as we have seen, it has slits along its length. And those slits divide the so-called scallops. You see 2 scallops, but oftentimes there are multiple slits. And so this gives us difficulty in describing how many subsets there are in the leaflets. So there, I simply prefer to describe the aortic mural leaflet, which got closed along a solitary zone of apposition. We also have difficulty in describing how many leaflets there are in the tricuspid valve. And for better and worse, by calling it tricuspid, we recognize that essentially it has a septal leaflet, it has an inferior leaflet, and it has an antero-superior leaflet. But you'll see that there's a little notch there in the antero-superior leaflet, and so many would describe the valve as having more or less than 3 leaflets, but we should again considering it in its closed rather than its open position, so the valve closes in trifoliate fashion. And that's not what we're now going to look at. Diane's going to show you videos illustrating how the valves close, and then Justin is going to reinforce that again with more virtual dissections.
This is a short axis view from the base of the heart of a normal mitral valve, showing us the solitary zone of apposition between the much broader anterior leaflet and the more shallow mural leaflets. It's important to point out that the zone of apposition does not reach all the way to the valvar annulus. The mitral valve is also known for its multiple scallops that allow it to close in a very snug fashion. The tricuspid valve closes in a trifoliate fashion. So here we can see the anterior superior leaflet, the septal leaflet, which is attached to the interventricular septum, and the smallest of the 3 leaflets, the inferior leaflet, which is along the diaphragmatic aspect. So the tricuspid valve, in difference to the mitral valve, closes in a trifoliate fashion.
This is a 4D CT data set of a normal patient. We're looking from the left atrium down at the mitral valve. We can appreciate both the aortic and mural leaflet. The mural leaflet, we can see the scallops in it. We also can appreciate that although its length is shorter from its hinge lines to its tip, it takes up a much longer circumference along the left atrioventricular junction compared to the aortic leaflet of the mitral valve, which is much longer from its hinge line to tip, but taking up a shorter circumference of the left atrioventricular junction. And then if we play this 4D video, you can appreciate the bifoliate closure of the mitral valve. Then we'll look at the same patient now up at the mitral valve from the apice of the left ventricle, appreciating the aortic and mural leaflet of the mitral valve. We also can see the area of aortomitral fibrous continuity span between the right and left fibrous trigoon. We also, looking at the right side, common theme that I've emphasized, it's very difficult to homogeneously opacify the right side, making it difficult to appreciate the tricuspid valve in many CT scans, along with the fact that the tricuspid valve leaflets tend to be slightly thinner than the mitral valve. So we can't really, unfortunately, appreciate the details of the tricuspid valve in this example. And since I couldn't find a great example to show, instead we'll look at a 2D echo of a normal patient, and then we'll compare that with a 3D echo of a patient with congenitally corrected transposition, looking at the left-sided tricuspid valve that actually has a mild epstenoid malformation. So looking at the subcostal short axis 2D image here on the left, here's the septal, the inferior, and the anterosuperior leaflet of the tricuspid valve closing in trifoliate fashion. And we're basically looking at a mirror image over at this right-hand image of the patient with congenitally corrected transposition. And I'd be curious to hear how Professor Anderson would describe these leaflets in attitudinally appropriate fashion. But we're looking again, basically a mirror image, what would be analogous to the anterosuperior, the inferior, and the septal leaflet of the tricuspid valve, but better appreciating this trifoliate closure.
So what is it that holds the leaflets together when they are in their closed positions? And of course, it is the next part of the valvular complex, the tendonous cords. Now, there are multiple ways also to categorize the tendonous cords. But I think we should take the simple approach to this, and we should distinguish the cords as being those attached to the free edge of the leaflets, those that reinforce the ventricular aspect of the leaflets, we can call those the strut cords, and then the additional ones that arise from the ventricular wall and insert to the underside of the mural leaflets of the valves, and those are basal cords. So here you see a picture showing you the free edge cords, and as you see, they are attached all along the free edge, and then some of them branch, and they are fan-shaped cords, and typically they support the ends of the zone of apposition between the two leaflets in this valve, mitral valve. But I would remind you again, the zone of apposition does not lead to junction, because overall we have a skirt of leaflet tissue. We turn the valvar leaflet round and we look at its ventricular aspect. This is the aortic leaflet, mitral valve, and there you see the strut cords. But if we lift up the mural leaflet, we see these miniature papillary muscles there supporting the underside of the mural leaflet through the basal cords. So now we're going to look at this in further video clips, and we're going to see how well we can see the difference between the free edge cords, the strut cords.
This is an open view of a normal mitral valve, showing us that the free edge cords serve to uniformly support the mitral valve leaflets, and they attach to all leading edges of the valve. At the zones of apposition, the edges of adjacent leaflets, so a portion of the mural and the anterior leaflet, and again, mural leaflet and anterior leaflet, are supported or tethered to the same papillary muscle. So here you can see that zone of apposition with equal support between both the mural and the anterior leaflet. And often in this area, these cords will have a fan-like appearance at the zone of apposition. Also at the zone of apposition, there's a portion of valve tissue that separates the orifice from the annulus. Now, the strut and basal cords are on the ventricular aspect of the valve. And if we look at the ventricular aspect of the anterior leaflet, you can see all of these support cords extending onto that free ventricular aspect of the anterior leaflet. the basal cords are often a little harder to find, but they are attaching to the ventricular aspect of the mitral valve and typically very close to where it attaches at the atrioventricular junction.
Professor Anderson's requests are becoming increasingly challenging. Trying to show chordae by CT can be pretty difficult, and especially in children with higher heart rates, but even in adult patients with lower heart rates. So instead, I'm going to show an MRI data set of a scanned heart specimen. So this is cut in a funny angle, but we're looking basically at the long axis of the aortic leaflet of the mitral valve, looking from the right to the left fibrous trigone, spanning the area of aortic mitral fibrous continuity between it and the aortic valve. And we can appreciate, looking at this ventricular surface of the aortic leaflet of the mitral valve, we can see these strut chordae attaching to this, the ventricular surface. And then we'll dissect and we'll flip it around and we'll look at the atrial surface of the aortic leaflet of the mitral valve. And here, although we're not capturing all of them, you can appreciate the free edge chordae attaching to the free edge of the tip of the aortic leaflet of the mitral valve. And then we'll go back into more of a 3-chamber cut and focus back here at the mural leaflet. And you can see these basal chordae attaching more along the base, the ventricular surface of the mural leaflet of the mitral valve.
So finally, we come to the muscles that tether the tendonous cords, the papillary muscles. And they are positioned inferoceptally, superolaterally, mitral valve. They are eccentric in the tricuspid valve, and that in itself is important because the tricuspid valve itself has its own topology. You'll remember that at the end of our discussions for 2021, we discussed the importance of ventricular topology. And I emphasized that all structures have their own topology, and this is particularly true for the tricuspid valve and also the papillary muscles of the mitral valve. So here we see those papillary muscles of the mitral valve. To make this dissection, I've cut away the parietal wall of the left ventricle. We're looking at it from behind. One of the papillary muscles is adjacent to the septum, and as you see, is inferiorly located. The other one is supported by the lateral wall, and that is superiorly located. Turning our attention to the tricuspid valve, we see how eccentric it is. And one of the muscles is small, that is the medial papillary muscle. Another one is adjacent to the septum, supporting the zone of apposition between the septum and the inferior leaflet. The largest papillary muscle oftentimes inserts itself to the midpoint of the anterosuperior leaflet. And the key to understanding the tricuspid valve, the papillary muscles are very much eccentric, and it is that feature that gives the valve its own topology. So to complete our discussion of the atrioventricular valves, again, we're going to look at this morphology. Diane is going to show it to you again in video clips, dissected hearts, and then Justin is going to show you these features using virtual dissection.
We can assess the position of the papillary muscles by looking at the heart on short axis view from the apex and in attitudinally appropriate fashion. So if we look at the papillary muscles supporting the mitral valve and within the left ventricle, here we see the superior and lateral papillary muscle and the inferior and septal or more medial papillary muscle. Again, we can nicely see the solitary zone of apposition of the mitral valve. Looking at the tricuspid valve, the papillary muscles are located medially. This papillary muscle arising from the caudal limb of the septomarginal trabeculation. There is an anterior papillary muscle and inferior papillary muscle. Very often, the inferior papillary muscles are variable and they can consist of more than one small muscle.
We'll go back to our adult heart cut in a short axis, looking up at the AV valves from the apices of the ventricles, looking at the tricuspid and the mitral valve. And we'll pay attention to the papillary muscle support of the mitral valve first. And if we look at what is commonly called the posterior medial and the anterolateral papillary muscle, and we appreciate our orientation cube and the fact that here's the diaphragmatic surface, which is inferior to the heart, that this so-called posterior medial papillary muscle is actually more anterior. Here's the A face of the cube. So it's positioned more anterior than the so-called anterolateral papillary muscle. So if we describe this of how it relates in the body, then they have more of a superior-inferior relationship, and better described as the superlateral and inframedial papillary muscles. Now looking at the tricuspid valve papillary muscle support. This papillary muscle is again near the diaphragmatic surface. It's supporting often the inferior leaflet or the commissure between the inferior and the septal leaflet of the tricuspid valve, and is better referred to as the inferior papillary muscle. The anterior papillary muscle often either supports the free edge of the anterosuperior leaflet or supports the commissure between the anterior and the inferior leaflet. And then if we rotate this, and we can see often supporting the commissure between the septal and the anterosuperior leaflet is this very tiny and very important papillary muscle, the medial papillary muscle, which has other names of papillary muscle of Lancisi or papillary muscle of the conus. And so that is a much smaller papillary muscle, and it attaches at the posterior caudal limb of the septomarginal trabeculation and is an important landmark for where the right bundle branch will emerge along the endocardium of the rightward aspect of the interventricular septum.
So there we have it. What I hope we've shown you is that to understand the ventricular inlets, we need to look at the structures they enclose, namely the atrioventricular valves, and we need to approach them in terms of the valvar complex, junction, leaflets, tendinous cords, and the papillary muscles. And then in our final session, to review normal anatomy, we are going to discuss the valvar complex in the setting of the ventricular outlets. But when considering the outlets, we're also going to look at the myocardium that supports the pulmonary valve, the aortic valve, because what we will see in our final session is that there are much more differences in the ventricular outlets over and above the features of the valves themselves. Today, we have considered the atrioventricular valves occupying the ventricular inlets.
Amazing. It was a very, very nice presentation, beautiful images. I was texting the fellows here in my hospital. Guys, are you watching this? This is amazing. You really need to see that. So if they didn't have the chance, they can see again on YouTube. So today we have a lot of people on the panel. I'm very happy. Hi, Justin, how are you? Dr. Quinn and Norman. Norman, are still with my name? I cannot change it for you because I don't have the host privileges. You need to change yourself. But you look good as Grace. So thank you guys, amazing presentation. And please, everybody who was watching us today, type your questions on the Q&A chat box. And it was a very clear presentation. It was very good. And I'd like to start with Norman, as usual, to see his remarks about this presentation.
Well, this was a magnificent session. And one of the beauties of education is repetition. And so there's been a lot of repetition, but you fill in the gaps of your understanding with some of the new and interesting things that come out. For me personally, the most fascinating issue is something that we discussed at the last session, and that's when you look at the heart at 8 weeks of embryological development, it still looks like an AV septal defect because they have the infraseptal recess and the fibrofatty tissue has not yet completed that formation of the valve. So for me, the presentation again of the infraseptal leaflet and the inferior pyramidal space was extremely important. And also again, as an echocardiographer, where we call the papillary muscles anterolateral and posterior medial, we can see that they really are superolateral and inframedial. And what we have to remember as echocardiographers is that when we do a short axis, if you look at the angle of the transducer, it's not really in the short axis of the body, but it's in the short axis of the heart. And as Diane had so clearly pointed out to us, this is at 45 degrees off from the normal axis. So we have to remember that as echocardiographers. As echocardiographers as well, the central fibrous body is clearly visible. And with that also, you can see the infraseptal recess and the infrafibrofatty area. Perhaps, Justin, is a little bit more difficult, but from your pictures, it seemed that this was anterior to the coronary sinus. I don't know whether that's correct, but that's a question I have for you and for Bob. So those are certainly the important points that come up for me. One other question for Bob, as he mentioned that the tricuspid valve is described as having 3 leaflets and sometimes more. I came across an adult description recently of cardiac anatomy for transesophageal echo, where they described a 4th leaflet, usually in the septal leaflet, and what that looked like to me and what looked like on the specimen of Bob's was that this is an area of fusion between the superior bridging and inferior bridging leaflets embryologically, and perhaps, Bob, you can say something about that.
No, you're entirely correct in your comments, Norman. And also, I think your comments about the infraseptal recess and the developmental aspects and how we see this change. I had not seen the videos that Diane and Justin contributed to today until I watched the session today, and I had every confidence that they would match the slides that I had made in my PowerPoint presentation. And to me, I am amazed at how well they matched what I hoped they would do. And I thought that the presentations made by Justin, where he showed and he marked those using multi-planar formatting, that was quite spectacular. And to me, for him to show the interrelationship between the infraseptal recess, the apex of the inferior pyramidal space, it was exactly what I wanted him to do. And I thought that was truly spectacular. I mean, I had also the manipulation he has done with his data set. I noticed that one of the questions was his adult data set an MR data set or a CT data set? Justin, I think it's a CT data set, is it not?
Correct. All the living data sets were CT data sets. Some of them I used were from adolescents and some from adults. And then the heart specimen was a MRI data set. With that, we're able to, obviously in a heart specimen, we don't have to worry about breath holding. So we can really drive up the spatial resolution for MRI even further than usual when we're scanning heart specimens. But typically you wouldn't be able to get that kind of resolution, spatial resolution in a living patient by MRI.
I wondered how you were going to show us the tendonous cords, and you were right.
It was a challenge. Even a lot of the heart specimens I have scanned, it was a challenge to find one that showed it well.
But I think you did a wonderful job there. But perhaps you can tell the attendees how you made such beautiful images from that CT data set. But I think this is something that you've been taught by Shumpei, is it not?
Correct, and I'll also take the opportunity to answer Norman about the question about the coronary sinus. I had almost put into some of those images the relationship of the coronary sinus. So as we all know, and I think I've shown in prior of these educational series, that the coronary sinus, it runs in that left inferior AV groove, and then it opens up into the right atrium. And Diane had that beautiful dissection where she carved away the muscular tissue of the atrial buttress and peeled it away, and you could see what part of that was actually septum, where you would have a vestibular defect that I'm sure we'll eventually talk about, versus which part of that myocardium covered the beginning of the inferior pyramidal space, which was in front of or anterior to the entrance of the coronary sinus into the right atrium. So the coronary sinus is opening posterior to the inferior, running behind the inferior pyramidal space into the right atrium. Regarding the,
Sorry,
go ahead. Regarding the question about the image acquisition and how to create these figures, it's difficult to summarize in a brief format here. Again, I'll put a buzz in for the World Congress in 2023. We're organizing a anatomy 3D imaging virtual reality surgical simulation lab that will run throughout the Congress, where we'll have all experts of showing these kinds of, Dr. Shijong Yoon, who I see is on the panel today, will be doing a special section with that. And with that, I will be there along with hopefully Shumpei Mori to show people what we're doing with to create these data sets for virtual dissection. But we specifically use Xiostation, which is a Japanese software from Xiosoft. It's similar to a lot of the softwares that others use for these volume rendering. I would say that I think it has the best of both worlds of all the different softwares to do this. But it's a lot of thresholding, understanding the Hounsfield units for CT data sets or the signal intensity for MRI data sets, and manipulating that and combining volumes from the same data to show the structures that you want to show. So it's a pretty complex process, but time consuming to learn, but once you learn it, it's relatively simple.
And the images are amazing. Thank you very much for sharing with us.
Sorry, I wanted to just make one other point. I'm sorry for interrupting you, Justin. Thank you for clarifying that position of the coronary sinus there. As an echocardiographer, we get to see tendinous cords, and certainly the basal cords are easily seen. And I think that I would tell the echocardiographers on the panel that if you scan from the mitral valve leaflets very slowly in an inferior position, you can see the basal strut chordae quite easily on echocardiography. So come down and look at the basal strut chordae just as at the end of the valves, they separated from the valves and clearly not attached to the tips of the valve leaflet like the other tendinous cords are attached. That's it.
Shijong, do you have any thoughts, having seen what we presented today?
So I have here one question to speakers and Professor Henderson. The one question is that I have been paying attention to inferoseptal recess for a while, because I believe that it is a consequence, developmental consequence of engaging into the deeply wedged position for the aortic valve. And then my hypothesis was that in double aortic right ventricle with the bilateral infundibulum, inferoseptal recess should not be formed. But interestingly, in a couple of cases at least, I see that inferoseptal recess is still present in the presence of double aortic right ventricle with a bilateral infundibulum. What it means is that, I'm sorry that I'm using that terminology, but the septophobic, septophilic type of description, in double aortic right ventricle, I believe that both mitral and tricuspid valves should be septophilic. But however, the mitral valve still keeps its septophobic position. So that's some interesting observation I've made. And then I wonder, that gives me that questioning whether that position is due to that developmental consequence of engagement of aortic annulus into the space between the septum and aortic valve.
It's a very good point you make, Shi-Jun, and it's something we need to look at. I mean, I think your point is well taken. I think that the answer to your question is that during development of the valves, the larger part of the cushions end up on the left side of the septum. And I think that the zone of apposition between the two leaflets of the mitral valve, even in the setting of double outlet right ventricle, still is oblique. And I think that you will still have that area of fibrous continuity that's supporting the base of the atrial septum. And to me, that is the key of the infraseptal recess, that it supports the base of the atrial septum. And even in double outlet right ventricle, something has to support the base of the atrial septum. And you have multiplanar formatting, and you are an expert at doing that. So I think you need to look at it further. I think that when the aorta is wedged, it exaggerates the infraseptal recess. But I think that the point you make is a very good one. I mean, Justin and I are discussing this because even in some normal hearts, there can be very minimal formation of the recess. And we do believe that depends on the extent of wedging of the aortic root. But I think your point about double outlet right ventricle is another very important one. And we're still learning about the infraseptal recess. You commented yourself that you'd only begun looking at it very recently. I think Justin's demonstration showed us what we need to be looking for. I think we need to explore it further. I don't think all the answers are in yet, but I take on board the point you've made. Diane, you're with us, are you not? Diane, are you with us?
Yes, I'm here.
You remember when we looked at tetralogy of Fallow, and you took those lovely pictures of tetralogy of Fallow, and we looked at double outlet right ventricle then. And I think we noticed that there was the point that June was making about the valves. And this is something we need to go back and we need to look at again. You have lots of double outlet right ventricles, and I think you need to look at June's point.
Yeah, I think we do need to look at it. And as you also mentioned, there are some normal hearts that I have here that we've found that the infraseptal recess is either very shallow or non-existent.
And we need to explore those in greater detail. I think the presence of the infraseptal recess is one of the things we need to look at. As I said when I introduced the session today, it's probably new to most people. And June makes the point that even those of us who have been looking at it do not fully understand it yet. So lots of things still to do.
We have 2 questions from the audience. And just before that, I'd like to see if Dr. Quinn has something to add to the discussion.
Who's that?
Good morning. Hi. I think that was that Quintessenza? It was an abbreviation.
Yes.
So no problem. You know, obviously these are beautiful presentations with detail that, you know, most have never seen before. And I can tell you from a surgical standpoint, the ability to know what's behind structures, you know, when we're doing valve reconstructions or intracardiac reconstructions, you know, we're able to see the surface and understanding the anatomy at this detail to kind of understand what's behind or what's adjacent or attached as we're resecting or placing sutures. I just find this, you know, this continual learning at this detail, I think very, very, you know, just very valuable. So, and like I say, I continue to learn every time I see these, even after I've seen them a few times in the past. A couple of comments I would.
Your background is spectacular. Is that the new hospital?
Well, it's not too new, but it is the hospital. Yes, thanks.
Great background.
Thank you. One other thing I would also say is that what I would appreciate a little bit more is the surgeon's view of the AV valves. You know, we don't look at the AV valves from the ventricle that much, and a lot of the presentations, you know, are from the ventricular view. Just as a comment, if we could also just turn things around and look at it from the other side a little bit more, I think that would be of value and in terms of a practical, sense from a surgical standpoint.
Well, you noticed, Q, that I did show the mitral valve from the surgical aspect, and you must have seen more mitral valves than I have. Maybe you'd comment. How often do you see the classical tri-scallop effect, and how many times do you see multiple slits in the mitral valve?
I think that's the routine. And I think, we conceptualize a bi-leaflet structure, but we know the components within are variable. And I think you take each one, individually at the time when you're doing reconstructions and trying to assess what's prolapse, what's restrictive, understanding, where the chordaes are attached and all those things. But there's a lot of variability, and you just take each one as you're there. So
I think Adrian is unable to link into us today. Is that not the case, Grace?
Adrian is watching, but unfortunately we're not able to get him as a panelist because of problem with the link, but he's been watching us the entire time. Unfortunately, he was not able.
We can't hear him either.
Yeah, unfortunately, no.
Bob, can I ask one other
Adrian,
question?
I think if you raise your hand, I can, no, it's only Sasha that can make that. I cannot, and I don't have the host privilege of this meeting, and so I cannot make him a panelist, unfortunately. And I don't, even if he raises his hand, I cannot make him to speak. That's a shame. I'm so sorry.
Can I ask one other question just regarding the imaging of the, and I think it was Justin's MRI imaging of the specimen. I was amazed to see the detail with the chordae and papillary muscles that he achieved with that imaging. So is that only available? Is that only possible with a specimen, Justin, or is it possible to somehow use that technology to get it in the human?
In general, in general, MRI, we can drive the spatial resolution to 1 millimeter, sometimes down to about 0.7. CT, we're often able to drive that further, 0.7 to sometimes even lower in a living patient. And one of the main limitations with MRI is we have to breath hold, and it's related to also the temporal resolution, how fast their heart rate is. So with the heart specimens, obviously none of that comes into play in terms of having to breath hold and in terms of a beating heart. So we're able to really drive down that spatial resolution. So those heart specimens, we were able to get 0.4 millimeter resolution on MRI, which is not really possible clinically in a patient. Does that make sense?
Yeah, it's unfortunate.
So no.
You continue to work on this and get it to the point to be able to utilize it in a real patient.
Right. Well, I think that there's smarter people than me who are probably working on that to drive that clinically.
What about CT, Justin? Is there the ability? Can you not see it with CT?
Yeah, we can with CT in terms of the chordae and apparatus. We can not always to that detail that I showed, but we can see some of that detail. That again all relates to the patient size, how big these structures are related to what our spatial resolution we can obtain as how fast their heart rate is and so on.
I guess the reason that it's my fault that you didn't show the surgical aspects, because I told you to keep your clips short, but I guess you could show the view that Q's looking for with your CT data set, could you not?
Correct, and I did in the 4D videos, I showed the mitral valve from, along with that 3D of the tricuspid valve, the epstenoid tricuspid valve and congenitally corrected transposition. But I agree, we can certainly try to improve the clinical application.
Very nice.
Great, Grace, you had said there was some questions from the audience.
Omer is asking, what are the most consistent morphological feature that can differentiate right from left AV valves? then can we use this differentiation to define the ventricular topology?
Well, I can answer that. I mean, there's no question that the differences in the valves defines the topology. And I think Justin showed you beautifully, in fact, that the valve he showed you from congenitally corrected transposition was the mirror image of the valve he was showing you at the same time with his echo clip. And to an extent, this also answers the question that June and I and Justin were discussing last time. And June has his data set that we were arguing about. And I think he can go back to that data set and look for the topology of the atrioventricular valve in the ventricle, and that will tell us whether it's a right-handed or a left-handed ventricle. So the key feature for the tricuspid valve is that the papillary muscles are eccentric. And I think, to me, that is the key feature. The papillary muscles of the mitral valve are paired. The papillary muscles of the tricuspid valve are eccentric. And Justin, would you agree with that? That permits us to determine the topology?
Correct. Yes.
And
But
the
this
second
should be
question,
limited.
Is there a way I can share my screen with you for a moment?
of course you can.
Yeah, okay, let me just try this for you. I wanted to show you the this screen over here and just show you some echo pictures of the strut chordae that I mentioned that you can see. I don't know how well they're playing.
Absolutely beautiful.
Standing up from the papillary muscles, you get to see the valvar leaflets, and you can also see the chordae on the other side of the valvar leaflets. This one actually has a chordae tendonous cord attached to the posterior wall of the ventricle. And on this example here, you can clearly see the chordae tendonae that are separated from the valvar leaflets.
I mean, Norman, those pictures are quite exquisite, and they emphasize again everything that Justin and Diane have been showing you today, which is not surprising because you're showing.
Well, yeah, right. I mean, we're all showing the same things.
Absolutely.
But I just think that it's important for other people to appreciate that. Let me just freeze this one for a second and show you this attachment to a minor papillary muscle within the left ventricle there. Yeah, you can.
Beautiful.
Yeah.
A basal cord.
Yeah.
And I think that's a good general point, and something we should consider is many of the structures that we're showing with fancier imaging and with these beautiful dissections, you can see clinically, you can see with echo, and you can see with two-dimensional echo, but you have to have that foundational understanding to know what to look for first. So we certainly can try to start incorporating how to look at this by two-dimensional imaging.
And the other point,
Justin, you make a very good point. But I think that's what these sessions are all about, is we don't want to just look at a cross-sectional image. We want to really understand the morphology. And, you know, the more you understand as an echocardiographer what the morphology is, the better you are able to display it. And I think that's the point.
And Norman, if I could comment on those images you've just shown us, they showed without any question that the papillary muscles are inferoseptal and superolateral.
That's correct, Bob. Absolutely.
And the business that echocardiographers are unable to illustrate the attitudinally appropriate arrangements is nonsense, isn't it? As you say, when you know.
If you look at the subcostal images, they are in attitudinally appropriate fashion. So the problem is that certainly for the adult echocardiographers, where subcostal imaging is a problem, they are still looking at the anterolateral and posteromedial papillary muscles. But the minute you go to the subcostal view in that what I call a sagittal plane, which is a short axis plane, just looked at from a different point, they're attitudinally correct in the subcostal position.
Norman, would you agree? This is what I emphasize to my fellows with echo and relating it to cross-sectional imaging, is understanding the difference between body planes and cardiac planes. And in although you're not always, it's not like MRI and CT where you stay in an axial or sagittal plane.
Correct.
Your subcostal views are more or less body planes where you're sweeping through those type of planes. So that's why that relates it better to the body as opposed to your parasternal imaging where you're getting into cardiac planes.
No, that's exactly right. And one has to realize that. And then I think that if you look at where the parasternal short axis plane is, it runs on the body from the left shoulder to the liver. That's the short axis plane, which is completely off axis. And what it presents itself on the television screen as that the apex is in the apex of the triangle is in the front, and that's clearly not the place where it belongs. It belongs in a different place. Let me see if I can get hold of another illustration if there's some time on a subcostal image, and I'll show you that those are the issues. So I'll just have to look for one.
Grace, was there another question while Norman's looking for that?
And the question is for Norman as well. And I think we've been discussing a little bit of it, but it's Tia wants to know specifically on echo, how to differentiate the valve and the ventricle, especially when you have single ventricle. She said that she finds difficult to evaluate the smoothness of the ventricular walls without the other ventricle to compare.
That's another good point. And perhaps while Norman's looking at, because June made the very good point that in double outlet right ventricle, he anticipated that both valves might be septophilic. In fact, in double inlet left ventricle, both valves are septophobic, and they both look like mitral valves because the septum's in a different place. So I think if you're thinking about double, and of course there, she says single ventricle. She doesn't mean single ventricle because she knows that single ventricle.
Of course not, Dr. Anderson. We know that very well.
But it is the case that, and June, maybe you would comment on this. I think that's the case, is it not? That both the ventricles, both the valves tend to resemble mitral valves when we have double inlet left ventricle. I'm not sure that is the case with double inlet right ventricle.
So in that regard, that one may think about the two valves in the morphologically right ventricle should resemble morphologically tricuspid valve. And if your two valves in the left ventricle, mitral valve could be, but however, it does not make sense because that if you think about pathology as a spectrum, of overriding issues, and when to stop, we call mitral valve, when to stop, we call tricuspid valve, or the type of thing, depending on the severity of overriding. So it is a little bit of contentious, and still, I don't think the valve should be regarded as the topological criteria to define the ventricular topology.
That's not quite what I said. I think if each ventricle has its own valve, I said the valves have their individual topology, and we can prove that. If they're, as you say, if they're not, if each valve does not have its own ventricle, then all the rules are off. But when each ventricle has its own valve, the valve will go with the ventricle, and we'll prove that for you. You're still obviously skeptical, but we will show that that is the case.
That I don't know.
You have the
What did you find? Sorry.
You have the data sets yourself, June. You can play with it.
I will see.
Bob, it's really difficult to just pick up a specimen like that out of a database, but let me share the screen with you. This is from our little app, Bob. And so here you can see what we call an echomorphological correlation. Here is the valve with the superolateral and inframedial papillary muscles. And here is the position of the inframedial papillary muscle. And there is the supralateral papillary muscle there.
Absolutely.
So it's attitudinally correct. There's not a problem with it.
And anybody can get this by, all they have to do is buy your app.
That's right.
Cheap at the price.
For $8,
I can make a kind of a teasing question to you guys.
It's a real steal.
And when
for
you
$8.
have the congenitally corrected transposition with the left ventricle anterior, and then your anterior-posterior relationship between the superolateral and inferior septal opposite.
Well, they are mirror images. Then you have the septal leaflet is anterior, but the third leaflet is still inferior, even in congenitally corrected transposition.
Yeah, but what I'm asking is that should we still name that in abnormal heart following the normal nomenclature we use for the normal heart?
Well, Justin,
that was my question as well.
I think that in congenitally corrected transposition, we still have an inferior leaflet, we still have a septal leaflet. Correct me if I'm wrong, Justin, but the third leaflet will be supero-posterior, will it not?
I agree with you there. I guess my concern and question is, as you and I were discussing a little bit over email, is when you have different positions of the cardiac apex, you can have a number of positions, even if you have a right hand ventricular topology or left hand ventricular topology. And then that's where, as a clinician, I think it would become very confusing if we want to try to standardize naming of leaflets, if we just always describe it on its exact position within the heart.
But I think,
do you understand? But in the typical location of congenitally corrected transposition with left-hand ventricular topology, I agree. But when you start having changing of the apex of the heart, are we going to always name it exactly where it's positioned?
But I think one of the leaflets is always going to be septal, because as you have pointed out.
Correct, that's easy.
And the position of the cushions drapes across the septum. So irrespective of the location of the heart in space, irrespective of how it's rotated, one of those leaflets will be septal. And that's the point about the topology, which answers June's question. Wherever the septum is, the leaflet of the tricuspid valve is going to occupy it because it's positioned there from the outset of development. I think, Justin, you have June's data set, do you not?
We can email, but I don't have it in a format that I can use. I don't use the Mimics software.
So we need to get him to send it to you in a format you can use.
Yeah, I have sent you the DICOM data the other day.
Okay, I can look into that.
We know you're very busy, so we won't press you on that, but we will keep going on we will solve this problem.
It costs a lot of time. Just sorry that you're involved.
But it's worth it, June. It is worth it. Time well spent. Okay, Grace, have we finished all the questions?
I think so, and it's been an amazing session, almost 2 hours, guys. Thank you very much. We learned a lot, I'm sure. And please share the link on YouTube to your colleagues, because this is for sure a session that is worth being seen for everybody involved with congenital heart defects.
And Grace,
So,
before you go, is all the discussion also now available on YouTube? Do we have?
Yes, the discussion as well. Everything is available there.
So as you say, it's worth looking, as Norman says, it's something we have to repeat and we have to think of it again and again. And hopefully next week, for 2 weeks' time, we'll all also manage to get Adrian on board. I'm sorry we've not been able to get him on today. His computer problems are considerable.
Thank you very much. And for sure, Adrian's going to be there. And I'm sorry, as I'm not the host, I was not able to help him to log in. But for sure, for the next session, he's going to be here. So see you all on the 21st.
Indeed.
Thank you.
Thank you.
Thank you very much. Thank you, everybody, for attending.
Everybody.
Thank you, guys.
Happy New Year.
Thank you all.
Happy New Year.
Happy
Thanks,
New
and
Year.
Happy New Year and good health to all of you.
Thank
We
you.
need that. Thank you.
Bye, guys.
Bye-bye, guys.